Ever notice you bruise easily from just, bumping into things? Or maybe had a nosebleed that just seemed to go on forever?
Mm-hmm.
We often just shrug these things off, right? But sometimes they can be subtle signals of something actually surprisingly common.
That's right. Today, we're going to dive deep into von Willebrand's disease, or VWD as it's often called.
VWD, okay.
Yeah, it's an inherited bleeding disorder that, well, it affects quite a few people, and understanding it can really shine a light on why some folks have these persistent, maybe seemingly minor bleeding issues.
Exactly. So think of this as your focused exploration of VWD. Our aim today is to really unpack this condition, cover it comprehensively but, efficiently.
Yeah,
Perfect for revision.
sounds good.
We'll cover what it is, the causes, the risks, how it works inside the body, what else it might look
The
like,
differential diagnosis, yeah.
who it affects, how it actually presents, diagnosis, management, the outlook, and any potential complications down the line. Ready for a streamlined journey through VWD.
Absolutely. Let's start with the core definition. So von Willebrand's disease is fundamentally an inherited bleeding disorder.
Inherited, okay.
The central issue revolves around something called von Willebrandfactor, or VWF. It's a protein.
VWF, right.
And this protein, it has two really key jobs in how our blood clots. First, it helps platelets stick together at the site of an injury, that's adhesion.
Okay, sting platelets.
And second, it acts as a carrier, sort of a protector, for another vital clotting protein, factor VIII.
Ah, so it's like a glue for platelets and a bodyguard for factor VIII.
That's a great analogy, actually. Exactly. And for most people with VWD, it's passed down in an autosomal dominant pattern.
Yeah.
Meaning if just one parent carries the gene for VWD, there's a pretty good chance, 50-50 usually, they'll pass it on to their child.
Right. And what are the common sort of telltale signs?
Well, common clues that might point towards VWD include things like frequent or really prolonged nosebleeds, epistaxis.
Okay.
And in women, particularly heavy or extended menstrual periods, which we call menorrhagia.
Menorrhagia, got it. And I think you mentioned there are different types.
Yes, that's really important. We generally classify VWD into three main types.
Okay.
Type 1 is the most common. It involves a partial quantitative reduction in VWF. So basically, you just don't have enough of it.
Just not enough. Type 1.
Type 2 involves a qualitative defect. So the VWF might be there in okay amounts, but it doesn't work properly. It's faulty.
Okay. Quantity versus quality.
Exactly. And then there's type 3. This one's rare, but it's the most severe. It's characterized by an almost complete or sometimes total absence of VWF.
Wow. Okay. So type 1 low amount, type 2 faulty function, type 3 pretty much none.
You've got it. That's a good way to remember the basics.
Okay, yeah, it gives us a framework. Now let's dig into the reasons behind these VWF issues. What's the underlying cause, the etiology?
Well, the primary drivers are hereditary. It comes down to genetic mutations that affect the VWF gene. That's the gene that codes for the von Willebrand factor.
Makes sense.
These mutations can lead to either the body producing less VWF or producing VWF protein that's, well, dysfunctional.
And the inheritance pattern, you said mostly dominant.
Predominantly autosomal dominant, yes. That typically leads to type 1 and most type 2 forms, but there are rarer autosomal recessive forms too.
Recessive meaning?
Meaning you'd need to inherit the faulty gene from both parents to have the condition. This is usually what we see in the severe type 3 VWD.
Okay, mainly genetic. But you also hinted at acquired causes earlier, pseudo-VWD.
Yes, that's an important distinction. In acquired, or pseudo-von Willebrand's disease, the VWF problems aren't inherited. They actually pop up secondary to other underlying medical conditions.
Like what?
Things like lymphoproliferative disorders, some lymphomas, for example, myeloproliferative disorders, certain solid tumors, autoimmune diseases like lupus, and even some cardiovascular conditions like aortic stenosis.
Interesting. Anything else?
Yeah, certain medications can sometimes induce it, and even occasionally pregnancy. So it's crucial to look at the whole clinical picture, not just assume it's inherited.
Definitely something to keep in mind. Now, going back to those hereditary types, could we break them down a bit more, maybe with those MemoryHooks you mentioned?
Absolutely. Let's try. For type 1, think volume down. It's the most common, maybe 60–80% of cases. A quantitative defect, just not enough VWF.
Volume down.
Got it.
For type 2, think function fails. This accounts for maybe 20–30%. Yeah. It's a qualitative defect. The VWF doesn't work right.
Function fails. Okay. Now, type 2 gets a bit more complex. It has subtypes.
Uh-oh.
Yeah. So 2A, think absent multimers. The large VWF structures are missing or break down too easily. 2B, remember, binds spontaneously. The VWF grabs onto platelets when it shouldn't, leading to them being cleared out quickly and sometimes low platelet counts.
Binds spontaneously. Okay.
2B. Then 2M, think misfit binding. The VWF doesn't bind properly to the platelet receptors. And 2N, recall, no factor VIII binding. This one's autosomal recessive, and it looks a lot like mild hemophilia A because the factor VIII isn't protected.
Right, because VWF carries factor VIII.
Exactly. And finally, type 3 is totally absent. Rare, severe quantitative defect, almost no VWF, and it's autosomal recessive.
Wow, okay. Volume down 1, function fails 2, with absent multimeres 2A, binds spontaneously 2B, misfit binding 2M, no factor VIII binding 2N, and totally absent 3. That actually helps.
Good. Glad it's useful.
What about that platelet type VWD you mentioned briefly?
Yes, platelet type. That's quite rare. The issue there isn't actually the VWF itself, it's the platelet's receptor for VWF.
So the VWF is fine, but the landing dock on the platelet is wrong.
Precisely. Mutations in the receptor make it bind too eagerly to normal VWF. Paradoxically, this causes similar bleeding issues because the platelets get cleared out too fast. It's also autosomal dominant.
Okay, that's a lot of detail on the why. Now, who's more likely to get VWD? What are the main risk factors?
The biggest one, without a doubt, is family history.
Makes sense, given it's mostly inherited.
Exactly. If you have parents, siblings, or other close relatives with VWD or just a history of unexplained bleeding problems, your risk is definitely higher.
Anything else?
Well, consanguineous relationships where parents are related, like cousins, increase the risk of inheriting those rarer autosomal recessive forms, like type 3.
Right.
There's also maybe a slightly higher reported prevalence in Caucasian populations, although it affects all ethnicities. And a personal history is key, too. If someone consistently bleeds for a long time after, say, dental work or minor surgery, that should ring alarm bells for a possible bleeding disorder like VWD.
Really highlights the need to know your family's medical history. Okay, so we know what it is, who's at risk. How does this lack or malfunction of VWF actually cause the bleeding? What's the pathophysiology?
Okay, so the key is VWF's job in what we call primary hemostasis. That's the body's very first response when a blood vessel gets injured.
The first step in stopping bleeding.
Exactly.
Yeah.
VWF acts like a bridge. It helps platelets stick or adhere to the damaged vessel wall, and it also helps platelets stick to each other, forming that initial platelet plug.
So if the VWF isn't there or isn't working, that first line of defense is weak.
Precisely. If you lack VWF or it's dysfunctional, that crucial step of platelet adhesion and forming a stable platelet plug is impaired.
Right. Okay.
And that results in the prolonged bleeding that's characteristic of the condition. The severity of the bleeding generally correlates directly with how much functional VWF you have. Less functional VWF means more severe bleeding.
And that links back to the types, right? Type 1 less severe than type 3 usually.
Generally, yes. Because type 1 is a partial deficiency, type 3 is near total absence, and type 2 sits somewhere in between depending on the specific functional defect.
And can you just quickly remind us of those two main jobs of VWF again? Just remember.
Sure. 2 key functions. 1, attracting platelets and making them stick to the injury site and to each other. 2, binding to factor VIII and protecting it from being broken down too quickly in the bloodstream.
Fluid bodyguard. Got it.
So a problem with VWS hits both platelet function and the levels of another clotting factor, factor VIII.
Okay, that paints a really clear picture of the mechanics. Now, if someone comes in with these kinds of bleeding symptoms, what else might a doctor be thinking of? What's in the differential diagnosis?
Yeah, it's really important to distinguish VWD from other bleeding disorders, mainly because the treatments can be quite different.
Right.
A major one to consider is hemophilia, specifically hemophilia A or B.
How's that different?
Remember, in hemophilia, the deficiency is specifically in factor VIII for hemophilia A or factor I for hemophilia B. It's not primarily a VWF problem, although low factor VIII can be seen in some VWD types, particularly type 2N and type 3.
Okay, so different missing piece in the clotting cascade. What else?
Platelet function disorders are definitely on the list. In these conditions, the platelets themselves don't work correctly, even if VWF levels are normal.
So the platelets are the problem, not the VWF.
Correct. And then you also need to think about other rarer coagulation factor deficiencies problems with factors like 2, V, 7, or X. Each of these would need a different diagnostic workup and management plan.
So how do clinicians actually sort this out? How do they pinpoint VWD versus these others?
This is where specialized lab tests are Absolutely crucial. And sometimes genetic testing, too.
They kind of test.
Key tests include the VWF antigen assay that measures the amount of VWF protein, then the VWF activity assay that assesses how well the VWF is functioning. Ristocetin cofactor activity is a common way to measure this function.
Antigen for quantity, activity for quality.
Exactly. We also measure factor VIII levels given the relationship. Genetic testing can identify the specific mutation in the VWF gene, which can help classify the type.
Any others?
Well, the bleeding time test used to be common, measuring how long a small cut bleeds, but it's less specific and less used now. Platelet function tests, or PFTs, help rule out those platelet disorders we mentioned. And APTT, which is a general clotting screen, might be prolonged, especially if factor VIII is low, but it can be normal in milder VWD.
So a whole panel of tests really needed to nail the diagnosis.
Yes, it requires a targeted approach. You often start with basic blood counts, but these specialized coagulation assays, usually ordered by a hematologist, are what confirm the diagnosis, help classify the specific type and severity, and really guide the management plan.
Okay. Now, how common is this condition? What's the epidemiology look like?
It's actually surprisingly common. Estimates suggest that in the UK, around 1% of the general population might have some form of VWD.
1%. That's quite high.
It is. It makes it the most common inherited bleeding disorder by far. Globally, the incidence is estimated around 125 per million people. But it's really important to stress that most of these cases are mild, type 1 mainly.
Right. So many people might not even know they have it.
Potentially, yes. Or they just put up with symptoms like easy bruising or slightly heavier periods. Interestingly, it seems to be diagnosed more often in females.
Why is that?
Likely because heavy menstrual bleeding, menorrhagia, is such a noticeable symptom, prompting investigation. Also, there's some evidence that individuals with blood type O tend to have slightly lower baseline VWF levels, which might make symptoms a bit more apparent if they also have VWD.
Fascinating. That 1% figure really sticks with you. So with this wide range of severity, how does VWD typically show up? What are the common clinical features?
Well, as you said, the presentation varies hugely depending on the type and severity, but the classic signs, the things to look out for, include easy bruising,
Okay.
prolonged bleeding after injuries, cuts, or surgical procedures like tooth extractions, frequent nosebleeds, epistaxis, especially ones that are hard to stop.
Right.
And as we mentioned, heavy or prolonged menstrual bleeding menorrhagia in women. Some people might also experience bleeding from the gums or, less commonly, gastrointestinal bleeding.
And what about at the more severe end, say type 3?
In severe VWD, like type 3, you can sometimes see spontaneous bleeding episodes, particularly into joints similar to hemophilia, causing pain and swelling, or even into internal organs. Thankfully, this is rare overall.
Still pretty serious when it happens.
Absolutely. There can also be an increased risk of excessive bleeding during or after childbirth, though, again, this is less common. Even minor bumps or dental work can cause significant prolonged bleeding in someone with moderate or severe VWD.
So it really impacts various aspects of life.
It can, and it's really crucial to consider VWD in any woman presenting with menorrhagia where other common causes like fibroids have been ruled out. And while extremely rare, it's worth noting that in very, very severe, unmanaged cases, life-threatening bleeding is a possibility.
That underscores the need for diagnosis. Okay, so if those clinical features raise suspicion, what are the key investigations again? Let's list them out clearly.
Right, the key lab tests for diagnosis. Number 1, VWF antigen assay measures the quantity.
Quantity again.
Number 2, VWF activity assay assesses function, often the ristocetin cofactor test or similar functional assays.
Function. Got it.
Number 3, factor VIII coagulant activity checks the levels of the factor VWF protects.
Factor VIII levels. Yep.
Number 4, genetic testing can identify specific mutations in the VWF gene, useful for confirmation and classification, especially in tricky cases.
Gene test. Okay.
Number 5, bleeding time test measures clot formation time in vivo, but less favored now due to variability and specificity issues.
Bleeding time, less common.
Number 6, platelet function tests to evaluate platelet activity itself and rule out primary platelet issues.
Platelet tests.
Number 7, APT, the activated partial thromboplastin time. It's a screening test that might be prolonged if factor VIII is low, but often normal in mild VWD.
APTT.
And sometimes more specialized tests, like looking at the VWF multi-Mercamer pattern, can help distinguish type 2 subtypes. But those first few are the real cornerstones.
So antigen, activity, factor VIII, maybe genetics, and ruling out platelet problems. That's the core workup.
Essentially, yes. Basic blood counts, like a full blood count, FBC, are usually done first to check platelet count and for anemia. But it's these specialized tests that confirm VWD, classify its type and severity, and allow the hematologist to really tailor the management.
Right. So let's move on to that. We've identified VWD. How do we manage it? What are the main treatment goals and strategies?
The main goals are pretty straightforward. Control any active bleeding episodes effectively and prevent future bleeding complications, especially around procedures or injuries.
Makes sense. How do we do that?
The approach really depends on the type of VWD and how severe it is. For very mild bleeding, like a minor nosebleed or maybe mild menorrhagia, an antifibrinolytic medication called tranexamic acid can be very helpful.
Tranexamic acid, how does that work?
It basically stops clots from breaking down too quickly. It stabilizes the clot that does form.
Okay. What about boosting the VWFF levels themselves?
That's where desmopressin, or DDAVP, comes in for some types. DDAVP is a synthetic hormone, similar to vasopressin. It works by triggering the release of VWF that's already stored inside the endothelial cells lining the blood vessels. This causes a temporary jump in both VWF and factor VIII levels in the blood.
How is it given?
It can be given as a nasal spray or by injection, intravenously, or subcutaneously.
But you said it works for some types.
Correct. It's generally effective for most people with type 1 VWD. However, it's typically not effective for type 3 because those individuals have no stored VWF to release. And it can be problematic, even contraindicated in type 2B, because releasing more dysfunctional VWF might actually worsen platelet clumping and low platelet counts. It also doesn't work for type 2N.
So you need to know the type before using DDAVP.
Absolutely. And even in type 1, the response can vary quite a bit between individuals. So often a DDAVP trial is recommended giving a test dose and measuring the response in VWF and factor VIII levels to see if it's a good option for that person.
Okay, so what if DDAVP isn't suitable or if the bleeding is more severe?
Then we move to VWF replacement therapy. This means giving concentrates that actually contain VWF and usually factor VIII as well.
Where do these concentrates come from?
Historically, they were derived from pooled human plasma. Nowadays, there are also highly purified plasma-derived products and even recombinant VWF products available, though recombinant factor VIII is more common than recombinant VWF currently.
And when is replacement therapy used?
It's the mainstay for treating moderate to severe bleeding episodes, for surgical prophylaxis in many cases, and it's absolutely essential for individuals with type 3 VWD. People with type 3 often need regular prophylactic infusions to prevent spontaneous bleeds.
Prophylaxis, meaning regular treatment to prevent bleeding.
Exactly. And sometimes patients can develop antibodies or inhibitors against VWF or factor VIII, which makes treatment trickier. In those cases, specific strategies like using recombinant factor VIII or bypassing agents might be needed.
Are there other general measures for managing bleeding?
Yes, local measures are important. Using tranexamic acid as a mouthwash for dental procedures, for example, or applying pressure, obviously. And a really crucial point is advising patients to avoid medications that interfere with platelet function, especially NSAIDs like ibuprofen or aspirin, unless absolutely necessary and discussed with their hematologist.
Good point about NSAs. What about managing heavy periods specifically?
For menorrhagia, besides tranexamic acid or DDAV replacement therapy during the period, hormonal treatments can be very effective. Things like the combined oral contraceptive pill or a progesterone-releasing intrauterine system, like the Mirena coil, can significantly reduce menstrual blood loss.
Okay. Any role for platelet transfusions?
Very rarely. Only in situations with severe, life-threatening bleeding where there's also suspected platelet dysfunction or extremely low platelets, perhaps in type 2B, and other treatments aren't working. It's not a standard therapy for VWD itself.
Right. Anything else on the management front?
Just to re-emphasize family screening, because it's inherited, it's really important to offer testing to first-degree relatives, parents, siblings, children of someone diagnosed with VWD. Even if they don't have obvious bleeding symptoms, they might have a mild form and benefit from knowing, especially if they face surgery or childbirth down the line.
That seems really vital. So thinking about the long term, what's the outlook for someone living with VWD? What's the prognosis like?
Generally speaking, with proper diagnosis and management, the prognosis for most people with VWD is very good.
That's reassuring.
It is. Of course, the severity and the specific subtype do influence the individual's experience and outlook.
Are there potential long-term issues?
Potential complications can include iron deficiency anemia from chronic blood loss, especially from heavy periods or recurrent nosebleeds. In severe cases with recurrent joint bleeds, joint damage, similar to hemophilic arthropathy, can occur, though it's much less common now with better prophylactic treatment for type 3.
And the challenges for women.
Yes, menorrhagia can significantly impact quality of life, requiring ongoing management strategies. And pregnancy and childbirth need careful planning and management in collaboration with hematology and obstetrics.
So specialized care is key during procedures.
Absolutely. Any surgical or dental procedure requires careful planning and often specific treatment beforehand to prevent excessive bleeding. But overall, the key message is that early diagnosis and consistent appropriate care allow most individuals with VWD to lead full, active, and healthy lives. Quality of life is generally very good.
That's great to hear. Now, just to round things off, could you summarize the main complications that can arise, perhaps if VWD isn't managed optimally?
Sure. The potential complications we worry about include anemia, as mentioned, from chronic bleeding, joint damage or arthropathy from recurrent bleeding into joints, mainly in severe undertreated cases. Life-threatening bleeding, though rare, is a possibility in severe VWD or during major trauma surgery if unprepared. Menorrhagia, which is a significant issue for many women. And challenges during procedures, increased bleeding risk during surgery, dental work, or childbirth without adequate preparation and treatment.
But the positive note is,
The positive note is that with proper diagnosis, tailored treatment plans, including prophylaxis where needed, and preventative strategies, these complications can largely be avoided or effectively managed.
excellent. This has been an incredibly thorough run-through of von Willebrand's disease. If we were to summarize the absolute key takeaway.
I'd say the essential thing to remember is that von Willebrand's disease is the most common inherited bleeding disorder, presenting across a wide spectrum from mild to severe. But crucially, we have effective diagnostic tools and a good range of management options available now that allow people with VWD to live well.
Absolutely. And for you listening, if you want to cement your understanding of any specific part, maybe the types or the treatments, just rewind and revisit that section. It's all laid out here for your revision. And perhaps a final thought to leave you with. How important is it really to pay attention to those seemingly minor bleeding symptoms? The easy bruising, the nosebleed that takes ages to stop, heavy periods, both in yourself and perhaps in family members.
That's a great point. Recognizing those subtle signs can be the absolute first step towards getting the right diagnosis, like VWD, and ensuring the right management is in place. Don't just dismiss them.
Wise words. And if you are revising for your exams and looking for more high-yield resources, do check out passthemsra.com and our free question bank at freemsra.com.
Definitely worth a look.
Thank you so much for joining us today for this deep dive into von Willebrand's disease.
My pleasure.